Thank you very much, Ali, and thank you everybody for joining us today. I know how busy everybody is, and I really appreciate everybody's time. I am Joel Diamond. I'm the Chief Medical Officer for a company called 2bPrecise. I'll tell you a little bit about that later in the presentation about how we're bringing some genomic and precision medicine insights to the point of care. But more importantly to me, in my other work, I'm a family physician. I've been practicing medicine for about 30 years outside of Pittsburgh, associated with the University of Pittsburgh Medical Center. And I've been involved in medical informatics for most of my life, really from the perspective of making it usable to physicians like myself at the point of care. I'm going to let him do his own introduction, but I'm very, very happy and honored to have Malik Purohit with me today, who is the Assistant CMIO at University Hospital Cleveland, and he'll give some of his background. But again, I think from the focus of our discussion today, really excited to be talking about this general idea of how we can really democratize and free up some of the precision medicine insights that we have to an entire organization. Malik, you want to give a little bit more background in yourself?
Sure, and just a quick sound. Joel, can you hear me?
Yeah.
Okay. Yeah. Good morning. Good afternoon, everybody. This is Malik Purohit. I am the Associate Chief Medical Information Officer at University Hospitals. I'm also the Clinical Innovation Lead for Transformation for UH as well. And we've been working with, I've been at UH about 2 years. I've been working with Dr. Diamond and 2bPrecise since I joined. And we'll talk about that as we go through the presentation. And really one of our key focus areas for UH as an organization is precision medicine and getting better patient care at the point of care for the patient in real time. And so this is one of the areas that we've been partnering with 2bPrecise on. So I'll turn it back over to Dr. Diamond.
Great, thank you very much. So listen, I don't really need to talk a lot about the value of precision medicine with this group. We all know that this is in the news every single day today. We know that we're generating an incredible amount of data from genomics and other omics sources today. The question is, where is that data coming from? Where is it going? How do we use it? How do we repurpose it? And we're sort of back to where we were with informatics and data problems many, many years ago with just regular labs and medications and imaging and things like that. And we certainly don't want to repeat the mistakes of our fathers, so to speak, with that. We do know, and again, I'm preaching to the choir here, that 6% of live births have some genetic component to them, which represents a great deal of problems with this. And if we look inside of our own NICUs, as well as we look at the sort of genetic odyssey of children in pediatric hospital, we're realizing where all this information is being both underutilized, underdiagnosed, or really even a bigger problem, having a difficult time informing clinicians of potential genetic information at the point of need. All of you know that the growth of genetic testing has just skyrocketed in the last couple of years. If we look at just the rate of genetic testing overall since the Human Genome Project a few decades ago, and if we look at the cost of genetic testing, all of this has exceeded Moore's law. So in any other technology that we've had in medicine, as well as any other field, we're really markedly outpacing that in terms of technology increase, knowledge increase, and the decrease in cost. And yet we're still trying to play catch up in terms of our information systems throughout the hospitals today. And I think there's a couple barriers here right now with this. One of the points that we're going to focus on is the point of care piece here. And that is most of the data today that you're seeing is still coming back on paper or as a PDF, which doesn't allow us to do all the other things that we do with other important data points. The second piece here is what I'll call rogue testing. It's still the wild, wild west out there. If we look at organizations, and Malik will address this in his own organization, we have lots and lots of different quote unquote rogue tests where people are either ordering a single gene test or maybe a panel that's related to their subspecialty. Sometimes the barriers to getting the right test may be some of the bottlenecks. For instance, one of the organizations I work for, a neonatologist, say if I want to get a full exome, I have to do that through genetics, but it's really easy for me to order a microarray as an example, even though the exome is what I believe is the right test, but I can sort of fast track things because going through the genetic counselors is a bottleneck in my organization today. And then this just huge amount of data, as I mentioned, that's not saved or being utilized discreetly and can't be repurposed by other clinicians. And I, again, to this audience, don't need to talk about the genetic odyssey of these children that are starting off, get a test or a panel done, see another specialist, another panel, et cetera, et cetera. And then the question is, at least nowadays, is why didn't we get a full exome or maybe even a full genome very early on in this patient's care that would have benefited everybody throughout the life of that child. And I think that speaks to the so-called arc now that we're seeing in the lives of these children, which is really starting in the genetic data that we're gathering in the preconception phase, in IVF, during prenatal testing nowadays, which obviously with non-invasive testing is now becoming more prevalent, and we're generating a ton more of genetic data during that. And then postnatally, NICU, diagnosis, et cetera, throughout this child's life. So this arc that we see, if we can get control of this data early on, and that data can be made available throughout the care of this baby prior to birth and postnatally, then that's really the idea of where we can start leveraging this data at the point of care. Let me turn things over to Dr. Purohit to talk about sort of their strategy and journey in informatics around precision medicine, which interestingly did not start around pediatrics. And I'll have him discuss a little bit more of that strategy and where they are today. Molly, go ahead.
Yeah, no, thanks, Dr. Hammond. Yeah, no, I think, starting with the quote below from my boss, our CMIO, Dr. Sunshine, precision medicine represents the emerging standard across multiple specialties. I think that is an obvious statement. I think in 2021, that doesn't require a lot of support. I think everyone sees the obvious nature of that statement. And then the other part of it is the access, right? Having providers, nurses, and others having access to meaningful and actionable information within their clinical workflow. That's the other part of it. That's the area that I think most organizations are struggling with now. And in our partnership with 2bPrecise, that's become, oh, sorry, can you go back? And that's where it's been a struggle for us too, but I think we've been enhanced with our partnership with 2bPrecise in that sense. And then, we started with oncology, really operationally. Oncology was where our clinical leadership was very invested in this. And so that was a natural starting point, but we're expanding to pharmacogenomics, particularly their psychiatric areas and SSRIs, MFM and Pediatrics as well. Thanks. So next slide, please. And, the data problem is everywhere, right? It's not specific to oncology, pediatrics, but as precision medicine accelerates and becomes more and more widespread, we have to find a way to get the right results and into the EMR and in a way that's meaningful in the workflow for our providers. Next slide, please. And, this is not an uncommon thing that we see, especially in my role as associate CMIO working with the EHR as one of our big systems. Getting the delivery of that information to the provider within the workflow in the EMR is key. Now, the nice thing about this is that when you do genetic testing, whether you do it in 2021 or did it in 2015, the results are stable. And so you can use those results for pretty much forever with patients. Now, we might learn more things, get new information about genetics, but as to what your exome is, that's going to be stable over time. And now we've just got to find a way to get that information in a meaningful way to providers in the EMR. Next slide, please. And this is the other part, interoperability. Dr. Diamond talked about this in some ways with the PDFs and data, but these are some of the things that I think all of us in all organizations deal with, which is the disparate EHRs, even in one system. In ours, for example, right now, we currently have 3 EMRs in our own system across 21 hospitals. And so that's an area we're trying to get better at in terms of communicating information with the EMR just for all of us. And then the data going from, getting a lab test at one place and having it come back to you in a method that data can be used. Oftentimes you get lab results or other things in a PDF format, which is great, but from a computer standpoint, it's unusable. And we want to get that into what's called discrete data, which is usable data in a meaningful way, and then be able to manipulate that data and play with that data to understand it better, and then streamline precision medicine workflows from the payment to the patient side all the way across, and then synchronize that with the phenotypical, meaning how the patient presents, combined with the genotypical data, which is their exome. Next slide, please. And then the other part is we've started a program of data literacy for our clinicians, because having the ability to have genetic information in the EMR is one thing, but then be able to take that data and then understand it, and then meaningfully understand how to address it with the patient, discuss it with the patient, discuss the probabilities, probabilistic thinking. And so that requires another level of education. And so we've noticed the gap there, and hence we've made it better for our physicians by having some of these courses. And one of the courses I co-teach with one of our epidemiologists to be able to get that information in their hands so they know how to use the data along with having the data. Next slide. So this is where I think 2bPrecise platform, and I'll turn it over back to Dr. Diamond.
Thank you, Dr. Pure, which is great. And I would like to say, and I'll extend a compliment to you, UH has done what a lot of organizations, I think, have tried to do but failed, and that is started with a clear strategy for precision medicine. A lot of organizations have sort of taken this sort of one-off piece of this and tried to solve it, and all they've done is created more and more data silos within their organization. So this very, very methodological approach to creating a strategy, you'll see how that fits in. From a technology standpoint, real briefly, and again, I don't want to make this a technology discussion, but really the use of technology. But 2bPrecise is a platform that sits in the cloud above the EMR, and that's important because without disparaging electronic medical records, they're really not designed to do things outside of the sort of transactional process. That means that if we can collect this data, which we do from various sources, we are agnostic to various labs. So that means various somatic labs on the cancer side, germline labs in other areas, and other data types. We're acquiring that data, and I'll say in the raw form from the lab. So we're not collecting PDFs. We're not trying to decipher written information. We're actually getting data from the sequencer, so to speak, storing that in a data model. At the same time, we're agnostic to various EMRs and other data sources, and that means all that phenotypic data can be combined and harmonized in this cross-clinical omics repository that sits in the cloud. And equally as important is that we're agnostic to knowledge sources. So in real life, what does this mean? It means that for the most part, genetic data, as Molly mentioned, is static and should be available for the rest of a person's life. The idea of test once and query often. The problem, of course, is that there is new phenotypic information occurring all the time. So if a patient's condition changes, can we look into the genome and say, are there insights there? Or are there certain clinical conditions that would ask us to do a particular genetic test? So those are the two circumstances, as an example. And the knowledge is changing constantly. So what was a variant of unknown significant today, tomorrow may be incredibly significant in this patient's genetic journey. So the ability to inform a clinician at the point of care, here's some new knowledge combined with something we might know already about their genetics, may provide a very, very important pearl into making a diagnosis or to helping with therapeutics of that patient. And I thought we could illustrate this a little bit with a fairly complex case here. And this looks like a mess on the screen, and it should, because oftentimes this is how we're presented with this data. So this is a case of a 9-year-old female who actually had a normal birth. She did have some prenatal genetic testing, which was normal based on that testing. Had some respiratory problems early in life, and then developed some gait instability and developmental delay prior to her 2nd year of life. And at age 4, really declared herself, which led to a diagnosis of a T-cell ALL. She received treatment at that time of prednisone and vincristine and some other treatments. Her care during that was complicated by the fact that she had some abdominal pain, seizures, et cetera, and was eventually diagnosed with enterocolitis and requiring a partial small bowel obstruction. This was associated with some multiple x-rays that this patient had, and then developed some neurological problems, which eventually led to genetic testing diagnosing ataxia telangiectasia, which then allowed for the resuming of the chemotherapy. So an interesting case here where there was a molecular-based cancer and then a molecular-based germline problem associated with this. And of course, some of the X-ray treatment that this patient had complicated their condition and actually helped declare some of that condition. This patient went on in life at age 6 to have some immune problems, and then started having, I would say, more typical problems later in childhood and early adolescence with some depression, ADD, et cetera. And we'll talk about the role of pharmacogenomics, where that plays as well. At the end of the day, this is a hard case to navigate. And if you think about your own difficulties and where you look for information and spend a lot of time searching within the EMR, if we change the paradigm a little bit, and this is our presentation again in any EMR, to be able to look at the gene-drug interaction, so pharmacogenomics, look at their germline profile, look at their tumor profile, and also have a digital format of looking at family history and being able to collect family history that also feeds into the same data model that we talked about earlier to be able to help with diagnoses, et cetera. And more importantly, to be able to look at this data longitudinally. So now you're seeing this data on a timeline, and really being able to hone in this timeline, whether that means to either look in a particular episode of care or to really focus back and look overall. But as you can see along the top, you're seeing that molecular data informs many pieces of this, whether it's the pedigree and family history, whether it's the pharmacogenomics affecting their tolerance of medications, or whether it's those genomic tests that were done, where do they fit into this picture? So one is to be able to just simply look at some of the prenatal testing when we talked about that ARC earlier, and seeing some of that karyotype testing. Did that play a role in this? In this case, probably not, but again, not to hunt and search and look for a piece of paper and read a report from this. To look at the treatment for their cancer and whether those somatic results in fact played a role in this. And then, as we talked about, this patient's response to Paxil as an example of an antidepressant that they were put on, and seeing that this is a drug that probably had a poor response because of metabolism and pharmacogenomics. Probably we could have used genetics to inform a better type of care as well. The somatic profile I mentioned, and be able to look at those results discretely is a big step up from the paper way we're looking at this right now. And then finally, I mentioned pedigree and how that fits into this entire process. And again, without disparaging the EMRs too much, we all know how inadequate that tool is, both to a genetic counselor, but even to a pediatrician at the point of care, to try to capture some family history pieces discreetly and use them as part of an overall data model. So I hope this timeline view in some ways is a relief to that view that I showed you of that patient's history before, which is often, in our best cases, good doctors who keep that running narrative somewhere as part of their SOAP note, but still so difficult to get at most of this information, and clicking around the EMR becomes very, very difficult. So we're sort of at the bottom of that half hour here. And I wanted to stop at this point. One, thank everybody for their time today. Dr. Bureau, I really appreciate your insights here. And I think this would be a great time to pause and really ascertain some questions, talk about the strategy at where pediatrics is fitting in there. And then really, I think bringing Dr. Purohit's expertise in bringing informatics to the point of care and where it lends itself into your organizations as well. So I'll stop here and thank everybody, but open things up to question and answering at this point.
So, Dr. Diamond, this is a question that we have heard, I think, just in general, around how sophisticated have we found the neonatology pediatric department so far at using this data? Is this truly a real problem? Are they doing okay with how things come through now? Or how can we really put a lens on and say, how effective are we at using this tremendous data set today in care, and how are we going to prepare ourselves for tomorrow? So if you can expand a little bit more on just kind of the status of the industry in this particular care area, I think that'd be terrific.
Yeah, that's a great question. I'll start off and then Molly can chime in here at UH a little bit. If our first slide, we referenced Grady Children's, that's doing a tremendous amount of work looking at, both parents' full genomes and babies' full genomes in the NICU. So from a data standpoint and from really being ahead of the curve, that's an example of where organizations are really starting to generate lots of data and really looking at an impactful piece both on care and even on return on investment from doing those tests. The problems, of course, is what do you do with that data? So you're generating lots and lots of data, but not really a good place to place that data. And then again, how does that data become useful outside of the NICU? And so that's the challenge I think a lot of organizations are having, that when we looked at that arc, and I think that's why this is such a good question, we may have information systems to help with just that narrow piece there. But really, once you start moving this around, it becomes very, very difficult. So that child later on, when they present to an ear, nose, and throat clinic at age 8, does that otolaryngologist know that there's some genetic information that may inform them about their hearing loss at that particular point of time? So I think we're seeing a big disconnect here between what I will say tremendous advancements in the use of precision medicine and maybe a lot of sophistication in information technology within the organizations, but a giant gap that exists between that genetic information and how that's represented, mostly because it's hard to represent that data within the EMR due to vocabulary standards, due to technology pieces, et cetera. And Dr. Purohit, I'll let you weigh in here, because I think, you and your organization, I think some of the neonatologists now are saying, okay, we'd like to start generating some more of this larger data set, exomes, genomes, et cetera. But where does that fit into the overall picture here, and how are we going to use this within the organization? So your comments would be great. And you're on mute, I think.
Oh, sorry about that. No, I think, great comments, Dr. Diamond. I think you're spot on with what you described. I'll sort of highlight one other factor that's going on societally that I think makes this much more relevant is, I think we've seen it across the nation where we're seeing higher ages for both paternal and maternal ages for the first-time child. That age has gone up significantly over the past decade, 2 decades, and so I think that makes it, to Dr. Diamond's first slide, where it talks about maternal age and its relevance, and not just maternal but paternal age both, and the relevance for potential genetic disorders and abnormalities. I think that it's much more relevant in today's world than it was even, say, a decade ago or 2 decades ago, with the changing dynamics of how we are having children in this country and beyond.
Great point.
So one has come across, I'm not sure if everyone can see the chat or not, but another question has come across, which is there are so many kind of social commentary opportunities to talk about the sensitivity of genetic and genomic information, and you're talking about infants and children. So the question here is, what is the sort of general feeling among parents, family members, whoever it has to be, about having this genetic work done so early in a child's life? And kind of the second part of this was, if in the cases where whole exome, whole genome is being done, that's a lot of data. So is there sensitivity around, the security and privacy around this data, which could impact the patient's complete life, whole life?
Yeah, and I think we're still in the thick of this right now, and sorting these issues out, as we are always with new technology. It's interesting. On one hand, I think about this because I talk to young parents a lot, and I still actually talk to young parents about their dilemma about should they save cord blood and pay the annual fee, and how useful will that be later in their life. Which is interesting because taking nothing away from potential future stem cell benefits compared to having that full exome or full genome data at birth and what that may be and be able to inform care throughout life is an interesting contrast. I do think the social impact of this is still one to be figured out. Now, one area that I think has been easier, we mentioned pharmacogenomics in this talk, and when people realize that this is just another aspect of medication safety and really has no impact in terms of other sort of privacy concerns or the ability for some nefarious use of this information, that's an easy starting place. The other answer to this, and it's somewhat of a smarmy answer, is people have huge concerns about data privacy and integrity until it's their child who has a rare or life-threatening illness. And then, of course, everything comes off with that, and people want more of that. I do think today we look at this information, and Dr. Purohit, I know in your organization, you look at this genetic data in some ways no different than other private health information and all the protections that go around that. But I also think in some ways that's maybe a cop-out answer, because there are larger implications of this data, particularly how do you safeguard that data early in life, and then how do you make sure that really the owners of that data are the patients themselves, or at least their parents. Malik, you have any thoughts on that?
Yeah, no, I think it's a really great question, great point. And I think, this is in life, I think we've seen many areas where technology is ahead of the policies and regulations oftentimes. And so that happens in pretty much all aspects of life for many reasons. And so I think we do certainly have to be very careful with that data. In our organization, we take the highest levels of measures we can in terms of security. But on the other part of this, I think, the sensitivity on this is, do insurance companies get access to this data? Do other people get access to this data? And those are issues that I think we're really dealing with, because they're relevant, right? Do your insurance rates go up because now you have some genetic testing done and it shows something? So those are some of the sensitivities we have to take into account, not just security from somebody hacking into the system, but really those that can rightfully access the data, are they misusing it or appropriately using it? And then second, I think there's a little bit of a stigma to some of these things. But the stigma part in some ways is really, the more prevalent this becomes, the less of a stigma it becomes. like my clinical specialty is physical medicine and brain injury. And with brain injury, one thing we saw was when it was such a less discussed topic, it became more of a stigma to have a brain injury. But now that it became ubiquitous better or worse, it became ubiquitous for many reasons, whether it be sports or OEF, OIF, those kind of things. But it became less of a stigma because it became more prominent of a conversation. And so as a result of that, it was more discussed and we could get to a solution faster. And so I think in many ways, we certainly have to be appropriately cautious about who has access to this data. But at the same time, once it becomes more common and the stigma is taken off of it, then I think we can actually use the data to come to a solution, whether it be medications, diagnoses, treatment, et cetera, and go from there.
Yeah, it's a great point, and I would only add on to that too. Is this is sort of my plea for having an informatics approach to this. Listen, data that sits on paper in a PDF form is always subject to misuse. When somebody says share records and you say okay, you see everything because you have no idea what's sitting in a folder labeled other somewhere. So having discrete data then allows people to control access to the data by rule and role-based technologies, et cetera. I also think that there's another piece of this. If you look at family history, and what does that mean in terms of protection of other family members' privacy, as we try to connect, which we've been trying to do for years, not just with genetic information, but a mother's chart, prenatal chart, with a baby's chart in general. How do you merge those people and protect privacy as well? So I don't mean to suggest that technology is the answer to everything, but if we ignore a technology solution at the start of this, then we get to be content and think we don't have a problem because the data is sitting as non-discrete data somewhere, and then it doesn't really bother us because it's sitting in that folder somewhere as I mentioned with that. So I think these are really, really great points as well. I don't know, do we have the ability to open to the audience here? Because I'd like to get a sense of the people on this call. It's hard with these Zoom calls not being able to see people, but really if it's possible to get sort of some feedback from the audience here, where you are in your own journey, I'll say, with precision medicine, and where some of your frustrations are with either technology or bringing this information to the point of care. So I don't know if we have the ability on the call to sort of call people out, or I'd love to hear from individuals out there if people are able to unmute themselves and talk about this.
Hi, this is Krista Martin from Geisinger. Can you hear me?
Yeah, Krista, thank you.
Hi. So I'm the Chief Scientific Officer at Geisinger, but also clinical geneticist, laboratory genetics. And I just would like a little more information about your platform and where you're pulling the data from. So is this stored genomic data that then is iterated on over time, and who does that? And how does that go from your platform into the EHR, or what pings it that you might want to look at that exome or genome data over time? And is it a database in that, I mean, you mentioned Rady and some other programs that are doing, active sequencing. Is it meant to be a shared database to be able to understand variants of uncertain significance, as you mentioned, other things, or how does that work?
Yeah, Krista, thank you very much. Great questions, and I'll try to dissect each of that, and hopefully I'll capture a couple different points here. In our model, again, we feel fairly strongly that there's data that does belong in the EMR, but more importantly, because we have the ability to allow clinicians, researchers, and other people to see this data within their workflow. So to the end user, our sort of, I'll say, secret sauce is the end user, if they're an Epic or Cerner or Allscripts, it doesn't really matter. They're seeing that data within their workflow as if it's their native EMR, even though the data is sitting in the cloud above the EMR. That allows us to do a lot of things. For instance, on a very simplistic level, variants of unknown significance, as you mentioned, probably don't belong in the EMR. Why? Medical legally, it's really, really hard to then say, well, there's a new piece of literature that's identified this as significant. Now I have to find all the patients and inform them, et cetera. It's a lot easier to be sitting above the EMR and then be able to inform people either by push or by pull that as well. And the second piece, Krista, as you mentioned, is the changing knowledge base. So if the knowledge is changing and then we can inform people either new knowledge, whether that's a variant at all, or that there's new clinical information associated with a particular gene, et cetera, then that can appear to be seamless within the workflow. So that's how we sit in there, and I can show you some other visualizations of that. The data sources you mentioned, again, it's important that we try to be as ubiquitous to those information sources as we can. So today, in our example, our platform, we're collecting data that's relevant in real time. That includes medications, problem lists, and laboratories and other phenotypic information as it is necessary to this. But we can always add other new sources of information, whatever that might be in the future. So again, the genetic data being stored in a data model that can also harmonize with that additional information and knowledge is sort of the key to the platform, if that answers your question. I hope I'm driving towards an answer to a couple of your pieces here. The last piece was, I think, about this network of data. I know that Rady, for example, is doing a great job of building this network with this. I often say we have to get our own houses in order to help others. So this idea of building networks of data is incredibly important. We sort of get one chance to do it right. So if we could start digitizing as much information, both genetic and phenotypic information early on, then the ability to democratize that, share that, or decide at what part of a network we want to share that for discovery, research, or collaboration as time goes on. So, Chris, I think you may be muted again, but let me know if I answered your question fully. I know there were a couple pieces there, so I apologize if I missed a couple.
Nope. Yep. Thank you very much.
No, thank you very much. And Krista, if I could ask, I know you guys at Geisinger, again, are way ahead of the curve here with this. It would be great to hear your thoughts on where you are. I don't know from a technology standpoint where you are in this journey, and Geisinger as an organization, looking at not just the pediatric data, but looking at the entire spectrum of precision medicine. Do you have any thoughts on that that you might share with this audience?
Yeah, I mean, we're definitely moving in the direction of how do we get this data accessible and ready to be used in everyday healthcare. We currently have several use cases for that as far as oncology and early detection for risk for cancer or cardiology. Have started discussions around next generation sequencing in the NICU with the goal of using that data over the lifespan. Our MyCode research project has sort of led the way for us starting to think about this on a more global size, where we have 175,000 exomes from our research participants. And now we want to transition that to our clinical patient cohort, which is sort of the process that we're now transitioning to.
Yeah, it's fascinating and it's interesting. I'd love to hear from other people on the call right now. I mean, this is exactly where we are at this stage of precision medicine in our adventure with this. I don't think anybody on this call thinks of this as new, but you could see that everybody's coming up at this from many, many different angles. So there is a technology play, but some of that's around labs, some of that's in interpretation, some of that's in storage, some of it's from the EMR standpoint. And so we've got all these little pieces moving here. And my sort of passion for all this is really to stop for a second and do what Dr. Purahat did at UH and say, let's take a time out and look at our overall strategy. These pockets will continue to grow and probably move in their own swim lanes, but is that fitting into a greater philosophy that we have for the organization, that eventually we're not going to have competing interests here. And that's what I thought was interesting, how they started really in the cancer space because they had such an immediate need for this, adult cancer, and then sort of migrated towards looking at behavioral health and outpatient management of medications, and then really starting to look into the other germline areas within the organization. If I'm not mistaken, was there another, I think somebody was trying to unmute someone else from Dr. Morse, maybe? Was that the case, or did I miss that?
No, Chris Tay asked the questions that that I was thinking about as well. So I live I'm the director of child neurology and pediatric sleep medicine, and collaborate very frequently with Krista, and was just wanting to identify whether or not the part of the digital solution that you were offering was a more expedited retrieval of the genetics information versus just that the data would be more organized, because one of the rate limiting steps always is how long does it actually take to process the genetics?
Yeah, so that's actually an important point, because we are gathering the data, I'll say the raw data from the sequencer, and file format and all those other issues aside, and storing in that data model means that it's immediately accessible. The second part of that is the interpreted data, which in fact may change, or the need to reinterpret data over time as well. And there's an immediacy to that as well. So to looking at either reports of interpreted data, or to be able to look directly at that data in real time, we feel very, very strongly that that should be no different than any other type of data that we're looking at, whether it's other laboratory information, et cetera. So that immediate retrieval piece only comes when you have a data model that's part of the, or accessible through the EMR, but not part of the EMR. That also, by the way, allows researchers to be able to asynchronously be able to look at that data and have a feed from that that may not necessarily have an immediate part of that. Dr. Purehead, I don't know if you have any thoughts from an access standpoint, or thoughts about from your organization. I know from a cancer standpoint that there's an immediacy of that data that changes from point to point, or from the discussions around pharmacogenomics, which are a more immediate piece of this, that are separate from some of the other discussions.
Yeah, I guess I think you've covered it well, Dr. Diamond. I think in general, I'll just speak. I think you made a point earlier that I'll refer back to about the organizational strategy around this, in the sense that we've partnered with 2bPrecise in our EMR. We actually have two, one in the ambulatory, one in the acute, and we're going to coalesce those in the next couple of years to Epic. But in the current state, what we have is the ability to have that data flow into a centralized place that's easy for clinicians to access. And then from there, we can sort of subdivide and say clinically, who's interested in going down this pathway, and then operationalizing it, right? Because it's easy to, not easy, but the IT part is actually self-contained, in the sense that we can get the data feeds done, we can get it set up, we can have the user interface, all that kind of stuff. But then operationalizing in the sense of who's interested in it, who's going to work with their patients on it, who's going to get the exome process done, who's going to work with labs and send us the data. And so there's a lot of operation that go into this aspect of it. And so we set up a general side for our organization that then other departments can plug into. Oncology, waved their hand first because they had a tremendous need for it for obvious reasons, so they came in first. But since then, we have many others raise their hands that we were really interested. We want to use the technology. So we have pharmacogenomics. One area is SSRIs in patients needing treatment for depression. And so as a result, that's an area that's been well developed. And instead of using a trial and error method with SSRIs, which is a common form, can we get to a better solution faster for the patients and get them to the right treatment? So that's a very natural way to do it. Some other ones we're looking at cardiology or anticoagulation. Same concept. Can we get them to the right anticoagulants earlier and faster for all the relevant reasons? And so we're going down, and then as others are realizing the value of this for themselves, the infrastructure has been set up for them to plug in. rather than creating a new infrastructure for each service line or organization or department within our organization.
Yeah, thank you very much. Great points. I'll also ask the audience here, which is interesting. We've been talking a lot to adult audiences, I will say, about technology around precision medicine. And, it's interesting how very rapidly things are changing. But, a few years ago, most of the discussion was the main barrier to adoption is who's going to pay for the test. So that's the reason why it's not getting adopted as quickly. And two, I'm not so sure it's part of the standard of care of what we're doing right now. But the frustration has always been on the pediatric side. It's been just the opposite. There's been widespread use of tests, kind of goes out to lots of different places and lots of different labs. The payment issue certainly is there, but becomes less of a discussion, particularly in the types of sick children that we're seeing. So those barriers seem to have not existed. And so the use of genetics has taken off tremendously, but the technology part of that has significantly lagged. And I guess the question is now are people starting to pay the price for that? Are they starting to feel the need for technology, or is the need to just kind of push ahead and become more the standard of care of everything that we do around the care of these patients, and see if genetics informs that as well throughout the life of the child? So again, I don't know how much we're able to unmute and people can speak up here, but it's a question I have of where you are in your organizations with this. Is technology keeping pace, or is it the other way around?
Participants can feel free to shout it out or use the chat, whichever you're more comfortable with.
Well, I think if we have no more questions here, I would certainly appreciate everybody's time today. We're coming up at the top of the hour here, and it's been really delightful for me to have an ability to talk to this this type of audience. And I'm really curious to start moving forward and seeing where people are along their journey. So please feel free to reach out to me directly. I know Dr. Bureauhead, you would encourage emails or discussions as well. So again, thank you very, very much for your time today and attention to this. I know how busy everybody is, and I hope everybody has a great holiday weekend coming up.
Thank you so much, Dr. Diamond. And any of our KidsX community or member org participants, feel free to reach out to me, Allie Arnett. I believe you all have my email at this point. I will pass along any messages or connect you directly. Thanks, everybody.
Thank you.